Assalamu alaikum. Good morning, everyone. On behalf of Dental Unit, I am Dr. Choi, Intern Doctor, Community-Based Medical College. Thank you all for being here today. The topic of today's seminar is a conservative surgical approach for treatment of large cystic ameloblastoma. We are honored to have our respected chairperson, Associate Professor Dr. Ruhul Amin sir, Head of Dental Unit, and today's speaker, Assistant Professor Dr. Mukhlesur Rahman sir, Head of Oral and Maxillofacial Surgery. Now I would like to invite our Honorable Chairperson, Dr. Ruhul Amin sir. Please come on the dais and take the chair for conducting the rest of the session. Thank you all.
Respected teachers and other audience, good morning. Our today's clinical presentation on oral and maxillofacial surgery. The today's speaker is Dr. Mukhlesur Rahman, was graduated from Dhaka Dental College in 2007 and he obtained BDS degree in 2015 and he obtained last FCPS in oral and maxillofacial surgery in 2025. Now, I would like to invite Dr. Mukhlesur Rahman to present his case.
Honorable Chairperson, respected teacher and my dear colleague, Assalamu. My topic is a conservative surgical approach for treatment of large cystic ameloblastoma. Thank you for giving me the opportunity to present today. With the permission of Chairperson, I would like to start my case presentation. Before I start case presentation, I will briefly discuss about ameloblastoma and dressing method. Ameloblastoma is a benign but locally aggressive odontogenic tumor arising from dental lamina, enamel organ or epithelial lining of odontogenic cyst. It has a highly recurrence rate if inadequately treated. It is most commonly occur 20 to 40 years of age. There is no sex predilection. It is mainly occur in mandible, especially posterior part of the mandible, body, ramus and angle of the mandible. Maxilla is rarely common but more aggressive due to thin bone and early sinus invasion. Etiology is remnant of dental lamina, reduced enamel epithelium, basal cell layer of oral mucosa, odontogenic cyst lining, especially dentigerous cyst. Ameloblastoma patient clinically present with slow growing, painless swelling of the jaw, facial asymmetry present, loose or displaced teeth, malocclusion, occasionally pain and paresthesia present, difficulty in chewing and speech. Clinical findings: buccolingual bony hard expansion, buccolingual cortical plate thinning and perforation, eggshell cracking in large cystic lesion. Radiographical feature in orthopentamogram showing in case of multicystic ameloblastoma, multilocular radiolucency, soap bubble appearance or honeycomb appearance. In case of unilocular radiolucency, often associated with dentigerous cyst-like presentation, well-defined corticated border, root resorption common, displacement of teeth or inferior alveolar nerve. Orthopentamogram showing multicystic ameloblastoma, showing soap bubble appearance, and orthopentamogram showing unicystic ameloblastoma, this one. CT scan finding bony expansion with cortical thinning and hypodense, well-defined area, soft tissue involvement in advanced cases. Classification: radiological type unicystic or unilocular ameloblastoma, multilocular or multicystic ameloblastoma. Histopathologically type follicular form, plexiform, granular form, desmoplastic, acanthomatous, basal cell layer variant. Treatment option: conservative approach, inoculation, curetage, decompression followed by inoculation. Degree dredging method, it is newly method. Radical surgery: resection with continuity, en bloc resection, resection without continuity, segmental resection. This one, en bloc resection, preserve mandible, and segmental resection, segmentally resected. Resection with condyle involvement, partial mandibulectomy with disarticulation, hemimandibulectomy with disarticulation, subtotal or extended mandibulectomy, total mandibulectomy. Slide show partial mandibulectomy, hemimandibulectomy. Slide show subtotal or extended mandibulectomy or total mandibulectomy. Reconstruction: autogenous bone graft, iliac crest, rib or fibula, alloplastic material, reconstruction plate. Now I am discuss about dredging method. The dredging method is a conservative surgical technique developed primarily in Japan to manage ameloblastoma while preserving jaw continuity. It aims to reduce recurrence risk with maintaining function and aesthetics. The procedure involves repeated removal of tumor tissue and stimulation of bone regeneration over multiple surgical sessions with an aim to reduce and jaw resection. Steps: Step 1, initial surgery, inoculation of the lesion through curettage of the cavity, creation of a control bony window. Healing period: allow shrinkage of the lesion cavity, encourage bone deposition. Step 3, removal of any residual soft tissue tumor and tumor island, curettage of the granulation tissue, maintains reduction of cavity size, repeats until pathological cavity is replaced by mature bone and no further tumor tissue. Step 4, complete healing, continual radiographic monitoring, final biopsy may be done to confirm the absence of tumor. Advantage of dredging method: avoid segmental resection, low recurrence, then simple inoculation, promote natural bone regeneration, maintain appearance and function. Disadvantage of dressing method: require multiple surgeries, long-term duration 6 to 18 months, not suitable for very aggressive or recurrent solid or multicystic tumor, require patient compliance. Recurrence rate: radical resection, lower recurrence rate 0 to 5%. Dressing method, low to moderate recurrence about 10 to 20%. Simple enucleation or curetage has high recurrence 55 to 90% recurrence. Ameloblastoma is a slow growing but highly invasive odontogenic tumor, require careful management. The dressing method offers a conservative yet effective alternative to radical resection, especially for unicystic ameloblastoma and carefully selected solid or multicystic lesion. It balances recurrence control with preservation of jaw structure and function. Then I start case presentation. My patient Alamin, 12 years of age, male, Muslim student, coming from Jainabazar, Sripur, Gazipur. He is referred from ENT department of CBMCB. He is admitted 20 January 2025. He is admitted with the complaint pain on the left side of the throat for 3 days, swelling on the left side of his face for 1 year. Presenting illness: according to the statement of the patient, he was reasonably well 1 year back. Then he developed painless swelling in the left angle of his lower jaw. Initially it is smaller in size, then it increases gradually and obtain its current size. He also complained pain on throat for 3 days. It is moderate in nature. It is aggravated during taking food and relieved by medication. He has no history of weight loss and hemoptysis. He has no relevant past medical history. He has no relevant allergic history. He lives with his family. He has 3 sisters and 1 brother. All of them are well. He belongs to middle class family. He is immunized according to national EPI schedule. His vital sign: blood pressure 110 to 70 millimeter of mercury, pulse 72 beats per minute, temperature 98.4 degree Fahrenheit, respiratory rate 16 breath per minute. His general examination: appearance ill looking, body build average, anemia, jaundice, cyanosis, colonoscopy, dehydration, all are absent. His systemic examination: all systemic systems are well. His local examination: there is a swelling present in the left side of the face. It is diffuse in shape. Color is normal, measuring about 6 into 6 centimeter in diameter, extended from anteriorly from angle of the mandible to angle of the mouth to angle of the mandible, and superiorly it is extended mid cheek to the lower border of the mandible. There is no visible scar mark. and no Angers vein present and no pigmentation present. There is no discharging sinus present and surrounding skin is normal. Palpation, temperature is normal, surface is smooth, margin is diffuse, hard in consistency, non-tender, fixed with underlying bone and free from overlying skin. Intraoral examination, mouth opening is adequate, swelling measure about 4 into 5 centimeter in diameter, extended from first molar to retromolar trigone. Buccolingual expansion is seen. All other part of the oral cavity, including tongue, floor of the mouth, soft and hard palate, buccal mucosa, anterior tonsillar pillar and uvula is normal. Parotid duct opening is also normal. Oral hygiene is average. Palpation intraorally. Non-tender, surface is smooth, hard in consistency, fixed with underlying bone and mucosa free from swelling. Provisional diagnosis. Sir. Differential diagnosis: ameloblastoma, odontogenic keratocyst, dentigerous cyst, odontogenic myxoma, ameloblastic fibroma. Investigation: biochemical test, ECG, radiograph, histopathology. Biochemical test, all are normal. There is no radiology. Orthopentamogram showing radiolucency present on body, ramus and body angle and ramus of the mandible. It is extended from first molar tooth to condyle and coronoid process, and also pushing of 8 molar tooth bud on mandibular notch and infraalveolar nerve pushing. Chest X-ray normal. Histopathology showing ameloblastoma. So confirmatory diagnosis is ameloblastoma on the left side, body, angle and ramus of the mandible. Treatment option is conservative surgery, enucleation, curetage, excision, dredging method, and radical resection, partial mandibulectomy. During enucleation of this case,
mandibular part segmental
conservative enucleation করা হয়েছে স্যার, ফার্স্ট স্টেপ enucleation. After enucleation and curettage, X-ray showing slight bone formation.
নরমাল তো ছবি থাকে
জি স্যার,
প্রথমটার ছবি থাকলে বিফোর
ও আচ্ছা আচ্ছা। স্যার লাস্টে দেওয়া আছে স্যার।
আচ্ছা ঠিক আছে,
জি স্যার।
ঠিক আছে, শেষ করুন।
After fast dredging, almost bone formation. After first dressing histopathology, there is no tumor tissue present. After second dressing, during second dressing, cavity shrinkage, almost bone formation occur. After second dressing, X-ray showing, most of the bone formation occur. After second dressing histopathology, there is no ameloblastic cell present. Opposite showing before and after. Radiolucency present, and almost of the bone formation occur. Patient picture before and after. Recent picture, and my operation picture. Thank you all.